A patient walks into the ER, they've got drooping eyelids, double vision, and they're really struggling to speak or swallow. Your first reflex might be to just, call a stroke code.
Right, which makes total sense.
Yeah, but what if I told you the real culprit wasn't a vascular event at all, but a jar of improperly home-canned green beans?
Oh, the classic board question.
Exactly. It's exactly the kind of left field presentation the boards just love to throw at you. We'll be breaking down all major concepts covered on the exam. I'm Harvey, and conceptually you can think of me as your enthusiastic guide today. As an MCCQE reviewer, my entire goal is to help Canadian medical students like you feel more comfortable and, confident with the exam review process.
And I'm Donna, your resident clinical analyst. We know that staring down board prep can feel like, well, trying to memorize an encyclopedia of totally unrelated facts. So we're here to connect those underlying dots and really focus on the clinical reasoning that actually matters. Today we're teaching strictly from reliable StatPearls articles focusing on section S04 GASTROENTEROLOGY.
Before we really get into the weeds, though, a quick but important disclaimer. This deep dive is for medical education only, not medical advice, and any clinical decisions should involve a qualified healthcare provider.
So what is our mission for today's session? We are going to dissect the highest yield exam presentations, the precise clinical definitions, and the most dangerous management traps surrounding acute diarrhea, bacterial gastroenteritis, and parasitic infections, specifically Giardia and Amebiasis.
Yeah, and then we're going to wrap it all up by solving that green bean mystery with a critical outlier that examiners absolutely love to test botulism.
I always feel like when a patient walks into the clinic complaining of a stomach bug, we enter this incredibly murky diagnostic landscape.
Oh, totally. On the wards, people use terms interchangeably all the time, but on the MCCQE, you need to be razor sharp with your clinical definitions. If the exam uses the word diarrhea, I know I can't just rely on a patient saying they went to the bathroom a lot, right? What are we actually talking about in a strictly quantifiable sense?
It's the perfect place to start, actually, because the exam relies heavily on those strict definitions. Clinically, diarrhea is defined as an augmentation of water content in the stool.
Okay, so hard numbers, what does that look like?
Right. To put hard numbers to it, normal water content is about 10 milliliters per kilogram per day in infants, or roughly 200 grams per day in adults.
Wow, okay.
Yeah. If a patient exceeds that volume, and it's happening for less than 14 days, you are officially dealing with acute diarrhea. But if it drags on beyond that 14-day mark, well, it crosses the threshold into chronic or persistent diarrhea.
That 14-day cutoff is definitely something to highlight in your notes. But here's something that always trips me up. Patients, and honestly a lot of doctors, call all of this gastroenteritis. The exam, however, seems to heavily prefer the term acute diarrhea. I mean, isn't that just pedantic wordplay?
It sounds pedantic until you break down the anatomy, which, as you know, is everything on the boards. The term gastroenteritis literally implies inflammation of the stomach, the gastro part, and the small intestine. But true gastric inflammation is surprisingly rare in these presentations.
Really? So the stomach is usually fine?
Mostly, yes. Even enteritis, the inflammation of the small intestine, isn't always a given. Take a disease like cholera, for instance. It causes massive, life-threatening fluid loss, but there is no classical inflammatory enteritis happening on a cellular level. So acute diarrhea is just the much more accurate umbrella term.
Okay, that actually helps reframe how I look at the gut. So we have acute diarrhea, and the first major diagnostic fork in the road is dividing it into two pathophysiological camps, osmotic and secretory.
Exactly.
I can never keep the mechanism straight, though. For osmotic diarrhea, what is physically happening in the bowel?
Picture the gut lumen as a tube. In osmotic diarrhea, you have these unabsorbable, osmotically active solutes just sitting in that tube. Because of osmosis, they literally pull water out of the body and into the bowel. The classic board scenario here is lactose intolerance. The patient lacks the lactase enzyme at the brush border.
So the lactose isn't broken down.
Right. It just sits there, pulls in water, and then the local bacteria start fermenting it.
Oh, and that fermentation is why a huge tip-off for osmotic diarrhea on the exam is a stool pH of less than 5.5, right?
Yeah.
The bacteria are churning out short-chain fatty acids as they ferment the sugar, driving the pH down.
You've got it perfectly. But then you have secretory diarrhea, which is a completely different mechanism and, well, where most of our infectious agents live.
So in the secretory camp, it's not a passive pulling of water. The bacteria or viruses are actively damaging the epithelial cells, causing them to essentially lose their minds and start dumping fluid and electrolytes into the lumen.
Well, you're on the right track, but the boards will actually try to trick you by lumping all secretory damage together.
Wait, really?
Yeah. The degree of that damage is highly testable. The exam loves to give you a stool analysis and ask you to interpret fecal leukocytes, specifically neutrophils.
I always get stuck when a question hands me a stool analysis. If I see neutrophils, what is that actually telling me about what the bug is doing?
Neutrophils are your body's frontline inflammatory responders. So if they are in the stool, it tells you you're dealing with an entero-invasive infection.
Entero-invasive, so they're digging in.
Exactly. The bacteria aren't just sitting on the surface, they are actively burrowing into the bowel wall, causing profound destructive inflammation.
Wait, so if I see neutrophils, does that mean I could just cross certain bugs off my differential entirely?
Absolutely. Finding fecal leukocytes instantly rules out viruses. It rules out Vibrio cholerae, and it rules out enterotoxigenic E. coli, or ETEC.
Because they just sit on the surface.
Right. Those specific pathogens cause diarrhea through toxins or superficial brush border damage, not deep tissue invasion. No invasion means no neutrophils.
Which brings us to, honestly, a terrifying management trap. Picture this. Question 12 gives you an adult patient. They're miserable, they have a fever, they're having bloody bowel movements, and they're begging for an antimotility agent like loperamide just to make it stop. I mean, my instinct as a compassionate provider is to give them relief.
Yeah, but if you click loperamide on that question, you've just failed it. Antimotility agents should be strictly avoided in adults presenting with bloody diarrhea or high fever.
Because we're essentially trapping the pathogen inside the body.
Exactly. Think about the mechanics. The diarrhea is the body's attempt to flush out an invasive, toxin-producing bacteria. If you chemically paralyze the gut motility, you lock those invasive bugs and their toxins inside the colon.
Oh, wow. That sounds bad.
It is. That prolonged exposure can lead to severe systemic toxicity or even toxic megacolon, where the colon acutely widens, loses all muscle tone, and risks perforating, which is a surgical emergency.
Okay, so knowing we absolutely cannot trap these invasive bacteria, let's talk about the bugs themselves. The exam loves to test inoculum size, right? Basically, how many swallowed bacteria it takes to ruin your week.
It's a very common question, yeah, because it speaks directly to a pathogen's virulence and its ability to survive gastric acid. Shigella and enterohemorrhagic E. coli EHC are incredibly resilient. They only need a microscopic inoculum size of like 10 to 100 bacteria to cause a full-blown dysentery infection.
And on the flip side, you have Vibrio cholerae. It's notorious for causing massive outbreaks, but it's actually highly sensitive to stomach acid. A patient has to ingest hundreds of thousands, if not a million, of those bacteria just to ensure a few survive the acid bath of the stomach to reach the intestines.
Precisely. Now, once they survive the stomach, how are they causing disease? There are three main strategies: adherence, invasion, and toxin production.
Okay, so ETEC is adherence, right? The classic traveler's diarrhea.
Yes, ETEC uses adherence. It produces a colonization factor antigen that lets it stick to the upper small intestine so it doesn't get flushed away, and then it starts pumping out enterotoxins.
While the invaders, like Shigella and enteroinvasive E. coli, actually penetrate the mucosal epithelial cells, multiply inside, and spread cell to cell, that cellular destruction is what gives you the bloody, inflammatory dysentery we talked about. But clinically, how do we know when a self-limiting bug has crossed the line into a dangerous infection requiring hospitalization?
The MCCQE will hand you specific red flags for that. You aren't admitting every patient with diarrhea. You're looking for a high fever, grossly bloody diarrhea, or signs of severe volume depletion.
Like profoundly dry mucous membranes.
Right, dry mucous membranes, decreased skin turgor where the skin tense when pinched, or a concerning drop in blood pressure with tachycardia.
But here's the thing that really scares me about these bacterial infections. Even if the patient clears the acute bug and the diarrhea completely resolves, the danger isn't necessarily over.
No, it's not.
The exam is obsessed with post-infectious complications. I've always thought of it like a hit-and-run accident. By the time the complication shows up, the bacteria have already fled the scene, but the immune system is still crashing into the body's own tissues.
That is a phenomenal visual, but let's add the clinical nuance to it. It's not just random crashing, it's molecular mimicry. The antibodies your body built to fight the bacteria accidentally recognize your own healthy tissues as the enemy.
Right.
If a question describes a patient developing ascending symmetrical muscle weakness starting in the legs and moving up a few weeks after a diarrheal illness, you must immediately identify Guillain-Barré syndrome and link that directly back to Campylobacter jejuni.
And what if they present with asymmetrical joint pain, maybe some eye inflammation, or painful urination a few weeks later?
That triad points to reactive arthritis, which classically trails behind infections by Shigella, Salmonella, Campylobacter, or Yersinia.
We also can't talk about bacterial complications without bringing up hemolytic uremic syndrome, or HUS. This is the classic vignette a pediatric patient presents with acute renal failure, a low platelet count, and hemolytic anemia a week after eating an undercooked hamburger.
You're looking squarely at E. coli 0157.H7, the quintessential EHEC strain. The pathophysiology here is so high yield.
How does it work?
Well, the bacteria release a Shiga-like toxin that specifically damages the endothelial cells lining the capillaries, particularly in the kidneys.
And because there's vascular damage, the body's platelets rush in to patch the holes, which forms microclots all over the place. That explains the drop in systemic platelets. But what about the anemia?
Imagine those microclots acting like a cheese grater inside the blood vessels. As the red blood cells are forcefully pumped through those narrowed, clotted capillaries, they're physically sheared apart and destroyed. That mechanical destruction is the hemolytic anemia.
Wow. Okay, so we've seen how bacteria do a hit and run on the gut, leaving autoimmune chaos in their wake. But what happens when the pathogen doesn't want to leave? What if it wants to, set up a permanent camp?
Then we're talking about parasites.
Exactly. That brings us to the heavyweights of the parasite world, Giardia and Amebiasis. This is your classic scenario for a returning traveler or a daycare worker with chronic diarrhea.
Let's start with Giardia duodenalis. The presentation is distinct, foul-smelling, greasy stools, steatorrhea, significant flatulence, bloating, and notably, usually no fever.
No fever, right.
Yeah, and it is transmitted via cysts found in fresh water streams, which are notoriously resistant to routine chlorination, or spread rapidly via the fecal-oral route in daycare centers.
The histopathology for Giardia is something you absolutely have to visualize. You ingest the cyst, and in the small intestine, it releases the trophozoites. On a smear, these trophozoites look exactly like a pear-shaped face staring back at you, complete with two nuclei that look like eyes.
It's very distinctive.
Honestly, I always found it incredibly creepy to look into a microscope and have a parasite making eye contact with me.
It is a bit unsettling. Functionally, that face has a ventral disc that acts like a suction cup. They attach themselves right onto the intestinal epithelium.
Do they invade?
No, they don't usually invade into the deep tissue, but their sheer physical presence disrupts the brush border enzymes and causes severe malabsorption. If you were to do a biopsy, you might see normal tissue, or you might see subtotal villus atrophy, where the intestinal villi are blunted.
Because they disrupt those brush border enzymes, a very common exam complication is a post-infection lactase deficiency. The patient clears the Giardia, but suddenly they can't tolerate dairy anymore, because their lactase enzymes were wiped out. So how do we treat it?
First line is usually metronidazole, but there are two massive traps here. First, the disulfiram effect. If the patient consumes any alcohol, even a splash of mouthwash, while on metronidazole, they will experience severe flushing, nausea, vomiting, and tachycardia.
Oh, that's brutal. And the second trap is pregnancy, right? Picture this vignette. Question 45 gives you a pregnant patient in her first trimester who just picked up Giardia from her toddler. Your reflex is metronidazole, all right, but it's contraindicated in the first trimester due to concerns about teratogenic risks, specifically cleft lip formation.
Exactly. So what is your alternative? In the first trimester, you pivot to perimomycin. It's an aminoglycoside, but unlike others, when taken orally, it stays entirely localized in the gut lumen.
So it doesn't cross the placenta.
Right. It has almost zero systemic absorption, meaning it never reaches the developing fetus, making it incredibly safe and effective for this specific scenario.
That's a beautiful workaround. Now let's tackle the other major parasite, Amoeba histolytica, the cause of amebiasis.
This one spans a wild clinical spectrum. A patient can be a completely asymptomatic carrier of shedding cysts, or they can present with fulminant dysentery, severe abdominal pain, and bloody diarrhea with thick mucus.
And pathologically, it's pretty aggressive, right?
Very. Amoeba histolytica is highly destructive. It causes direct tissue lysis. The absolute hallmark finding you need to know is the flask-shaped ulcer it creates as it eats into the submucosal layers of the colon.
And it doesn't always stay in the colon, which is the terrifying part. The ultimate extraintestinal trap on the exam is the amoebic liver abscess. The patient might not even have diarrhea anymore, but they present weeks later with right upper quadrant pain, a fever, and a tender enlarged liver.
And if they show you a CT scan or describe an aspiration of that liver abscess, look for the phrase chocolate-like or thick, dark, viscous fluid.
Historically, they called it anchovy paste.
Gross. I always get stuck on the Amebiasis treatment protocol, though. If a patient has a liver abscess and I give them a tissue-penetrating drug like metronidazole and the abscess shrinks and they feel totally fine, why do I absolutely have to give them a second drug, a luminal agent?
Because of the cysts. It's a critical public health issue. Metronidazole is fantastic at penetrating deep tissues and killing the invasive trophozoites in the liver and the bowel wall.
But not the cysts. Exactly. However, it is remarkably poor at eradicating the dormant cysts that are just hanging out in the lumen of the intestine.
Ah, I see. So the first drug cures the active invasion, but leaves a ticking time bomb in the lumen.
You've got it. If you only give metronidazole, the patient survives the abscess, but they become an asymptomatic carrier, silently shedding infective cysts into the environment. You must follow up the tissue agent with a luminal agent like paramomycin or diloxanide furoate to completely clear those cysts and break the chain of transmission.
A vital two-step process. Okay, we have covered an immense amount of ground regarding diarrhea, but let's circle back to that ER patient from the very beginning. We're going to pivot to an ingested pathogen that subverts all expectations. It's a foodborne illness, but it doesn't cause diarrhea at all. It causes severe constipation and triggers a life-threatening neurological emergency. We're talking about botulism.
Clostridium botulinum is a gram-positive, spore-forming, obligate anaerobic bacterium. But the bacteria itself isn't really the weapon, it's the botulinum neurotoxin, or borne, which is arguably the most potent biological poison on Earth.
The pathophysiology here is incredibly high yield. You need to know exactly how it works at the molecular level.
The neurotoxin is a zinc-dependent metalloproteinase. Once absorbed into the bloodstream, it travels directly to the peripheral cholinergic nerve terminals. It enters the neuron and specifically targets and cleaves snare proteins like SNP25.
I always try to visualize this because snare proteins can feel very abstract. It's not that the brain isn't sending the signal to move, and it's not that the muscle is broken. It's like the toxin cut the telegraph wires, the snare proteins at the very last relay station. Because those proteins are physically destroyed, the vesicles containing the neurotransmitter acetylcholine simply cannot fuse with the cell membrane.
That's a great way to think about it.
The acetylcholine message just can't cross the gap into the neuromuscular junction.
That analogy hits the nail on the head. The signal is generated, but it gets stranded at the terminal. Because acetylcholine is responsible for muscle contraction, blocking its release results in a symmetrical descending flaccid paralysis.
And it classically starts at the top, right?
Yeah.
The bulbar symptoms we saw in our ER vignettes.
Yes. The cranial nerves are highly susceptible, so the earliest signs are diplopia or double vision ptosis, drooping eyelids dysphagia, difficulty swallowing and dysarthria, difficulty speaking.
And the pupil.
You will also see fixed and dilated pupils because the toxin blocks the acetylcholine required for the pupillary sphincter to constrict. And returning to the GI tract, because the autonomic smooth muscle is paralyzed, the bowel stops moving entirely. You see severe constipation, not diarrhea.
Let's quickly break down the three main types of botulism that the exam will test, because the mechanisms of acquisition are completely different.
First is foodborne botulism, like your green beans. This is due to the ingestion of preformed toxin in improperly home-canned foods. The anaerobic low-acid environment in the can allows the spores to germinate and produce the toxin, which you then eat. Onset is rapid, usually 12 to 72 hours. Second is infant botulism.
Right, the classic don't give honey to a baby rule.
Yeah.
But why is honey dangerous for a 6-month-old, but completely fine for you and me?
It comes down to the gut microbiome. Adults have a robust, heavily populated microbiome that outcompetes botulinum spores, preventing them from germinating.
Oh, so the spores just pass through us.
Exactly. Infants, however, lack that mature competitive inhibition. So if they ingest spores from raw honey, the spores actually germinate inside their GI tract, colonize, and produce the toxin internally. This leads to the classic floppy baby presentation.
And the third type?
The third type is wound botulism, where spores infect devitalized tissue, frequently seen in the context of subcutaneous injection of black tar heroin.
Now, when it comes to diagnosis and treatment, there's a massive urgency trap that examiners love to spring on you.
Yes, there is. You might read about the mouse lethality bioassay for detecting the toxin in the serum, but the golden rule is that diagnosis is clinical.
Do not wait for lab confirmation, right?
Do not wait for lab confirmation to initiate treatment. The paralysis can rapidly progress down to the diaphragm, requiring mechanical ventilation. The treatment is the immediate administration of an antitoxin. For adults, we use a heptavalent equine serum antitoxin. For infants, we use a human-derived botulism immune globulin.
And what about antibiotics? If an infant has bacteria actively colonizing their gut and producing toxin, wouldn't we want to just nuke the bacteria with antibiotics?
That is perhaps the most dangerous trap of all. Antibiotics are strictly contraindicated in infant botulism.
Why?
If you give that infant antibiotics, it causes the bacterial cells in the gut to lyse or burst open. That lysis releases a massive, catastrophic wave of preformed neurotoxin into their system all at once, severely worsening the paralysis. Interestingly, antibiotics like penicillin G or metronidazole are indicated for wound botulism, but never for infants.
That is terrifying, but makes perfect physiological sense.
Yeah.
And there's one more medication class to avoid entirely in any botulism patient, right? Aminoglycosides.
Yes, aminoglycosides are absolutely contraindicated. Think back to the mechanism. We know the toxin stops acetylcholine release. Well, aminoglycosides physically inhibit presynaptic voltage-gated calcium channels.
Oh, and you need calcium to release vesicles.
Exactly. Without calcium influx, vesicles can't fuse anyway. So if you give an aminoglycoside to a botulism patient, you're hitting the exact same vulnerable process from a second angle, dramatically potentiating the neuromuscular blockade.
It's just a perfect storm at the synapse.
Ah.
Okay, let's take a breath. We have covered an immense amount of high-yield ground today. Let's do a rapid-fire recap of the most crucial MCCQE traps we've discussed. First, the fecal leukocyte differentiator neutrophils in the stool mean an enteroinvasive infection, ruling out viruses and toxin-mediated bugs like E-tech or cholera.
Second, always anticipate post-bacterial complications. Look for hemolytic uremic syndrome from EHE 0157.H7 and recognize Guillain-Barré syndrome trailing behind a Campylobacter infection.
Third, Amebiasis requires a strict two-step treatment, a tissue agent like metronidazole, followed absolutely by a luminal agent to eradicate the dormant cysts and prevent the carrier state.
Fourth, if you're treating Giardia in a pregnant patient during their first trimester, avoid metronidazole due to cleft lip risks and use the non-absorbed paramomycin instead.
And finally, the absolute contraindication of antibiotics for infant botulism to prevent massive toxin release, and recognizing that botulism presents with descending flaccid paralysis and constipation, completely subverting the typical food poisoning presentation.
To wrap up, we want to leave you with a final clinical scenario to ponder on your own time.
Oh, I love these.
Consider how you would manage a patient presenting with an acute onset of severe watery diarrhea who recently finished a long course of broad-spectrum antibiotics for a respiratory infection. Your first thought is naturally C. difficile. But what if their stool sample surprisingly comes back completely negative for C. diff toxins?
Ooh, curveball. What else could be hiding in that disrupted microbiome? Could it be Klebsiella oxytoca, causing antibiotic-associated hemorrhagic colitis? Or perhaps a systemic fungal overgrowth?
It's a great question to chew on and exactly the kind of puzzle you'll face on the wards.
Good luck with your MCCQE preparation. Keep digging into the why and the how behind the facts, because mastering these underlying clinical mechanisms is exactly what transforms a good candidate into a great physician. See you next time.